Hi, everybody. Thank you for joining us today for our Cancer and Ketogenic Metabolic Therapy Research Updates and Practical Tips webinar. This is Laura Doherty from Functional Formularies, and I'm really excited today to introduce our two guest speakers who are just from an amazing group of ketogenic community RDs. The first presenter is going to be L.J. Amaral. She is a registered dietitian who is also board certified in oncology nutrition and the founder of Oncology Nutritional Science by L.J. She attended the University of Connecticut, where she obtained a Bachelor of Science in Nutritional Science, and then went on to get her Master of Science in Clinical Nutrition and Dietetics from NYU, while subsequently completing her internship to become a registered dietitian at Memorial Sloan Kettering Cancer Center in Manhattan. She now works in a large academic medical center in LA as a clinical research dietitian and is researching the efficacy of the ketogenic diet as an adjunct to standard of care therapy for CNS malignancies. So I'm really excited for LJ to get started here. I will say we have a lot of people on the webinar today, so for whatever reason, if you have any tech issues in terms of losing sound, because that can sometimes happen, please just refresh the webinar and or log in and log out, and that usually resolves that issue. We will also be taking all questions and answers at the end of both presenters. And your CEU certificate will be sent out by the end of the day tomorrow. You'll get that in an email. If you don't get it in an email, please reach out to me and I will get that to you as soon as possible. So without further ado, I know LJ and Denise have some great content today, so I don't want to take up any more of their time. I am going to let LJ get started.
Welcome, everyone. Thank you so much, Laura and Denise, for being here this morning. I'm really excited to be talking about this topic. Today, we're going to be discussing the ketogenic diet for cancer, talking about research updates, and then Denise will go into practical tips. There we go. Okay, we are both advisory consultants for Functional Formularies, or Nutritional Medicinals LLC. Our learning objectives for today are listed here. We would like you to understand the history of the diet and oncology. We would like you to identify appropriate candidates for this therapy, gain some practical tips on the diet and how to monitor for criteria for people who could benefit from the diet, as well as resources that can be very beneficial for you and your patients. So just to get started, I wanted to briefly discuss the shift in metabolism that we see and how it relates to cancer. So how do we normally get energy? This is a very busy slide. We're going to keep it nice and concise. We don't need to go over organic chemistry or the Krebs cycle in detail, but I just wanted to talk about the transformation of pyruvate to acetyl-CoA and the Krebs cycle in terms of oxidative phosphorylation and normal cell metabolism. So in general and under normal conditions, we use glycogen, or the storage form of glucose. We go through glycolysis to create single forms of glucose in order to be converted into energy. And so we have a single form of ATP that has been broken down from a single mole of glucose. It goes through the TCA cycle. Under aerobic conditions or oxidative phosphorylation, we end up with 34 to 36 moles of ATP as our final product after the electron transport chain. The only other thing I would like to highlight on this slide is that within the Krebs cycle, there are a lot of those protein intermediates that can get recycled into the cycle to recreate glucose. So that's just something to keep in the back of our minds. So shifting over to fat metabolism and ketosis, which is where the diet gets its name, we take our fatty acid from outside of the cell, we shuttle it inside of the cell into the mitochondria, it goes through beta oxidation. Similarly, we make an acetyl-CoA, and it has that go through, on the right-hand side, you can see the transformation of two acetyl-CoAs into the 3 different types of ketone bodies. So this also normally happens, ketone body metabolism, the creation of ketones happens within the liver. So glycogen is our glucose stores, and after about 24 to 48 hours of fasting or without having food, our body can naturally adapt to using ketone bodies as this alternative fuel source. So the KMT, or the ketogenic metabolic therapy, or the ketogenic diet, its goal is to have your body shift its metabolism from using glucose or carbohydrates or sugar as the main energy source, and instead shifting over to ketones and ketone bodies and having that be the primary energy source for all of our cells, organs, brain, muscle, liver, the tissues that typically utilize glucose. So what we don't know and understand or have a big protocol for is what is the threshold for ketosis. Most people, and what we use in our clinic, is serum beta hydroxybutyrate, or BHB, and that threshold for us is 0.5 millimole per liter, meaning that if you have a patient who's using a blood glucose ketone monitor and their ketones show up as 0.5 and above, we would consider that to be in a state of ketosis. So we do like to use the blood ketone monitors as the gold standard, and that's because BHB, or beta hydroxybutyrate, has had the most research implications in terms of how it can affect cancer and one's overall health. But there are also two other different ketone bodies. One in particular that I'll mention is acetate, and that also gets excreted on our breath. And so if you see people using any breath monitors, they are using acetate, or they're measuring acetate in the breath. Oh, and the last thing I'll mention is unused ketones are excreted in the urine, and over time, urine strips do become inaccurate because you become a little bit more fat adapted, meaning your body is used to being in this metabolic state, so it's not so readily excreted, and instead it's being used as energy because we can't store ketone bodies. We can store fat, of course, but as you'll see along the presentation, most people end up actually losing weight on this diet. So there aren't a ton of fat reserves. So that's something to keep in the back of our minds. Just to talk about the history or the background of the diet really briefly. So this has been a very well-established medical treatment for refractory pediatric epilepsy, and it started at the Mayo Clinic in 1920. So we are almost at 2023, which is insane to me, but that's over 100 years of this use of the diet in children. So we have kind of pivoted now to using not only the diet for pediatric epilepsy or inborn errors of metabolism, but now we're using it for other medical conditions like cancer, type 2 diabetes, and actually it's been very well established in some neurodegenerative diseases in preclinical models such as Alzheimer's, and it's really growing over the years. So just a little tidbit, and you can see on the right-hand side over here, this graph that I got from PubMed. So over the last, couple hundred, or the last 100 years, they're seeing a huge increase in publications as it pertains to the ketogenic diet and different types of medical conditions. So just for reference, in 2021, there were 615 publications related to ketogenic diet and medical conditions that are outside of epilepsy and inborn errors of metabolism, whereas in 2001, there were only 37. And this is largely based on the metabolic theory known as the Warburg effect, and that's how this all relates to cancer. So what is the Warburg effect? It is a metabolic phenomenon that was discovered by Nobel laureate Otto Warburg in the 1900s. And he discovered that cancer cells have an altered metabolism. So on the left-hand side of the screen, you can see a differentiated tissue or a normal cell, and how it can utilize glucose very efficiently. So you can see with oxidative phosphorylation or anaerobic glycolysis, you're getting 36 moles of ATP per mole of glucose, or 2 moles of ATP for glucose without the presence of oxygen. However, if you're looking at the right-hand side, which is the Warburg effect, where you see mostly in solid tumors, they have this altered metabolism. So what we see here is that cancer cells use glucose with or without the presence of oxygen and still only get 4 moles of ATP per 1 mole of glucose. So that is a incredibly inefficient use of our energy, and it can explain sometimes why people have something like cancer cachexia. And this is also really the main mechanism behind us thinking that the ketogenic diet could be beneficial for cancer, because if cancer cells are already having this increased affinity for using glucose and they're kind of addicted to it almost, and they're not even producing enough energy in comparison to normal cells, then maybe by altering the types of energy metabolism that we're giving them, we could also then alter the tumor metabolism and potentially abrogate growth. So, what is the ketogenic diet? So the ketogenic diet has many different ratios and different ways that you can implement this diet. So ratios meaning the amount of grams of fat in comparison to protein and carbohydrates combined. So when you see something like a 3-to-1 ketogenic diet, we're talking about this graph on the right-hand side. 87% of your total calories are coming from fat. You have about 10% of your calories coming from protein and 3 coming from carbohydrates. So we describe it as a high fat, moderate protein, and very low carbohydrate diet. And I think this is where a lot of confusion comes in, because a lot of patients will think that the ketogenic diet is like a South Beach diet or an Atkins diet, when in reality, the one that we use in our clinic, especially within brain tumor patients, is we do recommend restricting protein to an extent, because we do want to try to mitigate the amount of protein intermediates that go into the TCA cycle. So it can vary person to person in terms of what types of ratios that you would want to recommend, depending on the type of person, where they're at in their treatment plan, anticipated side effects. And so again, we want to talk about how the KMT or the keto diet mimics the metabolism that is seen in fasting. So going back to some of the first slides, because we're using beta oxidation and we're trying not to use glucose metabolism, our body gets tricked into thinking that it is in a fasting state. And so the KMT does get its name from the byproduct of fat metabolism, which is ketone bodies, and that's how we got to the ketogenic diet. Just to briefly talk about MCT, because the MCT oil diet is a form of a ketogenic diet, because it allows for a little bit more carbohydrates to be consumed. And that's because MCT is a length of fat where it is kind of like the perfect size for our body to absorb without having to go and break it down. So it can go straight into our portal vein to the liver to create ketone bodies. And so for a lot of people, especially if they're trying to, maybe they have a lot of kids at home and it's really difficult for them to eat really high fat and very low carb, this is a nice way to supplement their diet, and it really blunts the response of blood glucose, and it allows for people to have a little bit more flexibility. I also wrote down here that BHB, or beta hydroxybutyrate, which is the main ketone body that is created through the MCT oil intake, studies have shown that it could actually be a potential antioxidant. So being able to mitigate damage from other cancer cells or perhaps from cancer-directed therapy. So that's something I think for future direction in terms of research, and something to think about if you are a cancer dietitian or practitioner and you are counseling these patients who are going through chemo or radiation and need to avoid high dose antioxidants. You may want to be careful about the amount of BHB that you're using, but that's also to be discussed and determined in future studies. So why do we want to consider the diet for cancer? There's a lot of things listed here, and there are studies to support these claims. And I'll tell you anecdotally from my own practice, we have seen a lot of patients have these benefits. So of course, we have some decreases in glucose because we're changing the diet. So as we shift our fat intake, most of the fats that we recommend that people consume are long chain or polyunsaturated fats, so that can decrease one's inflammation. Ironically, people lose weight on a high fat diet. We lose a lot of water weight with the glycogen, and carbs actually do help us retain water weight. Most people do report that they have better sleep and improved mood, and we'll go through some of the studies that support that. And then I do want to highlight the last asterisk. So there are some studies, especially in preclinical models, that support the use of the ketogenic diet to sensitize the cells, the cancer cells, to being more apt to receiving the cancer-directed treatment and then dying off later. So that's what I mean by it could increase the efficacy of chemo or radiation. But there are certain conditions where it would not be effective or helpful, and Denise will go into that further. So to start with our first deep dive into research, I love this article. It is one of my favorites. I reference it constantly, by Dr. Barbara Koffler. It came out in 2019. It is a literature review article, and it is searched all of the literature that was available from 1979 up until 2019 involving the ketogenic diet and cancer. And so the primary outcomes of this study were to look at tumor size or weight and survival. And then secondary parameters were looking at alterations in vascularization, or the amount of blood vessels that go to the tumor, glucose uptake at the site of the tumor, gene expression patterns, metabolic parameters, etc. And so there were 87 total studies that were included in this literature review. 30 were clinical studies and 57 were preclinical studies. And so just to briefly talk about preclinical studies, those are the ones that we use before we go on to our human studies. So those are the in vivo or cell studies, and then animal or mice models. In the preclinical studies, as per this review, there is very strong evidence supporting the use of the ketogenic diet for cancer. And so most studies showed that the ketogenic diet, in conjunction with chemotherapy or radiation or cancer-directed treatment, it slowed tumor growth, it prolonged the survival rate, it delayed the initiation of new tumors, and it reversed the process of cancer cachexia in mice. And so other studies also showed that the ketogenic diet can sensitize cancer cells to classic chemotherapy or radiation. Something I thought that was also very interesting is that they noted that those who are on a PI3 kinase or phosphatidyl inositide, I just destroyed that word, but that's okay. PI3 kinase inhibitors, the ketogenic diet works extremely well because hyperglycemia is the #1 side effect of this drug. We do need to be careful though with preclinical data, of course, because there's no control group and we cannot directly translate from a cell line or an animal directly to human or clinic. So let's talk about the clinical studies, which are the studies that are done in humans. And so of the 30 studies that were included, most of these studies, unfortunately or fortunately, were case reports and pilot or feasibility studies, meaning that they were done in very small amounts of people, and they do not they're not randomized controlled trials, so they can't direct our recommendations for clinic, is what I'm trying to say. So there were, multiple reports of reduction in glucose, which is kind of on par with getting into ketosis, of course. And then, it was kind of a little bit all over the board with feasibility. Well, we can definitely do it in terms of feasibility, quality of life. I meant by retention. There was definitely some issues with retention in terms of people not wanting to do this for a long amount of time. There was an inverse association with BHB and IGF-1 or insulin-like growth factor. So as the ketone bodies went up, growth factor went down, which is great for tumors. No major adverse events were reported, and many case reports were reported with excellent therapeutic dose responses to the ketogenic diet, and we'll go over that in detail with a pilot study. This is a beautiful image by Beth Zubak-Kania and Denise, showing what research is supported for what tumor sites. And this is part of a keto mastery class that I highly recommend that is run by Denise and Beth, and she'll go over that in a little bit more detail. So the major conclusion from the keto and cancer, where do we stand? So 2 slides back, that This does have the potential to enhance anti-tumor effects from chemo and radiation. It does have good safety and tolerability. In most instances, it did increase people's quality of life. And like we were saying, we do need more randomized controlled trials to make sure that this is actually efficacious and making a difference in people's tumor sizes. So just to go a little bit deeper into some more research, we have the Ergo pilot study. This is one of the first clinical trials in humans. It came out in 2014, and this only had 20 patients, but that's actually kind of a large number for people who have glioblastoma, which is considered a rare tumor, actually. 15% of the 20 people actually discontinued the diet early because of poor tolerability. It showed that overall the diet can safely be applied to GBM patients, and it did enhance the effect, especially with patients who are on bevacizumab or Avastin, which is a VEGF inhibitor, which is the vascular endothelial growth factor. And that's also somewhat one of the mechanisms that the ketogenic diet does as well, is by reducing the amount of glucose or vasculature that's going to the tumor, it reduces the amount of nutrients that is going to the tumor. So this study showed in particular that keto with Avastin could be very beneficial for most patients, especially with a GBM. Moving right along, this is a pilot study that I worked on. This was 6 years in the making for me. It's how I got into research in keto in general. So on the left, you can see our consort diagram with the flow chart. We had 12 patients who had expressed interest in doing the diet. We basically did a retrospective pilot study in these patients. So 12 patients with mixed malignancies, all CNS malignancies, as you can see on the right-hand side. The table shows their disease status. And then we had 2 cohorts. So we were super lucky to have this amazing serendipitous opportunity with this Epigenics Foundation, who gave us some money and allowed us to provide meals and snacks for all of our patients in cohort 1, where there were 8 patients in that cohort. And then we have cohort 2. We kind of ran out of funding, but we still wanted to continue offering this to our patients. So those patients just received meal plans and dietetics support. So just bear in mind that only 8 of these patients had available glucose and ketone data. So in table 4, I wanted to just note the improvements mainly in symptoms for these patients. And what I would like to mention briefly is patients A through H are the cohort 1. So those are the ones who did receive meals. And then I through L are the ones who just received meal plans. What I would really like to highlight in this table is the physical mobility and strength, as well as energy and fatigue improving in almost everyone, and if not, being stable. And that's kind of unheard of when you're going through, especially brain tumor treatment. Most people feel weaker or they feel more fatigued as they go along. So the fact that they had improvements in comparison to historical control is pretty great. I am not a neuro-oncologist, so I'm going to very briefly discuss these MRI images, but I think that it's so incredibly powerful to see. I was a skeptic when I first started doing this 7 years ago, and so I have to see to believe, and so I always like to show evidence. On our left-hand side, we have a very young patient who had a grade 2 oligodendroglioma. On the left-hand side, it was his baseline pre-keto MRI. On the right-hand side, that is only day 60, and there's a huge decrease in contrast enhancement. On the right-hand side of this slide, we have a recurrent glioblastoma patient. Baseline pre-keto is on the left, and on the right-hand side is, again, only 60 days on the ketogenic diet, and there's almost no contrast enhancement. Lastly, I wanted to show this other patient who was also on a clinical trial. He was on an anti-DLL3 ADC agent. So on the left-hand side, it's again pre-keto, and then all the way over on the right, day 144, he continued on the diet with this clinical trial, and again, we see very little contrast enhancement. So this was very promising for us. It's how we started with our phase 1, which we have completed and will be publishing very soon, and we are actually now going to be working on a phase 2 to see if this really has efficacy within the brain tumor population. To wrap up our research recap, we have the largest randomized controlled trial to date that was done at the University of Alabama within ovarian cancer and endometrial cancer patients. There were 45 women who completed the intervention, and the women were randomized. So 20 women went into the American Cancer Society diet, which is a high fiber, low fat diet, versus 25 women in the ketogenic diet phase, who completed the, gosh, how many weeks was it? I can't even remember. I want to say it was only 4 weeks. I'm sorry about that. But the inclusion criteria were that people had to be BMI of 18.5 or above. The ratio of the ketogenic diet was 70% fat, 25% protein, and 5% carbs. They did look at DEXA scans, fasting insulin, fasting IGF-1, BHB at baseline and at 12 weeks. Oh, 12 weeks, there we go. At the end of the 12 weeks, there was a big improvement within the ketogenic diet group in terms of their reduction in fat mass. They had lower fasting insulin, and they also found that there was an inverse association with IGF-1 as well as BHB. They also reported that these women had less cravings for carbohydrate food, which I think can be beneficial, and in terms of saying this can actually be feasible, even if you think that you can't overcome the mental block of I need carbs. People actually felt like their cravings went down as the study went on. We have another one within breast cancer patients. This was done within Germany. A total of 29 patients went on a ketogenic diet versus 30 patients who were on a standardized diet. Again, people were 18 or above for BMI, and the median time on the diet was only 35 days. They did do this while patients were in both chemotherapy and radiation, and it was for curative radiation. I'm sorry, they had chemotherapy before. This was during their radiation. They were looking at dropout rate, changes in body weight, changes in fat-free mass, fat mass, skeletal muscle mass, extracellular water, total body water, intracellular water, and as well as changes in bioimpedance. They only limited carbs to 50 grams per day, but they did recommend that women only consume 10 grams of carb per meal, and they did also supplement this with MCT oil. So they did say that this diet is feasible for breast cancer patients who are going through radiation. It can reduce body weight and fat mass while preserving fat-free and skeletal muscle mass, which again is corroborated with other studies in terms of having the KD preserve lean muscle mass and not promote or further cancer cachexia. So lastly, to put a nice bow on this, since we've got a lot of research going on here, this systematic review just came out in 2021, and this was 45 publications in total were included in the systematic review. There were only 3 randomized controlled trials, 2 controlled trials, 33 single-arm studies and case reports. So all in all, there were 765 patients described in a total of 39 studies. So the therapy included all forms of the diet to reduce carbohydrate intake that aimed to achieve ketosis for patients with different types of cancer. So there were no conclusive evidence for the anti-tumor effects of this diet or overall improved survival. The majority of patients did show weight loss and had very mild, if anything, moderate side effects. They did note that the adherence to the diet was quite low in most of their studies. And they did also mention that the results were very heterogeneous in terms of the methodological limitations, in terms of no one had the same protocol going from study to study. We only had 3 randomized controlled trials. And so we really can't have a full-on sentence that says the ketogenic diet is efficacious for cancer, but we're getting there. So to recap the research, it is feasible to do the ketogenic diet in cancer patients, even if they are going through cancer-directed therapy. In most instances, it is safe to do so, and Denise will go into more detail for that. In the preclinical setting or animal-based models, the ketogenic diet is very, very strong. The evidence is very strong for using this as a complement. And we have to bear in mind that there are very few randomized controlled trials within this arena to show efficacy, but we do have lots of evidence to show that it's safe and it's feasible. And now we need to show that it is actually efficacious.
Great. Thank you so much, LJ. That was absolutely phenomenal. So we are going to switch over presenters here. So I want to introduce Denise Potter, who has been a registered dietitian for 31 years. And for the past 15 years, she has focused on ketogenic medical nutrition therapy. She's been privileged to speak to, train, and educate professionals and individuals around the globe on keto therapy. She also strives to provide client-centered, personalized therapy, counseling, and education, and really has a passion for serving the for helping underserved populations. She's also the author of The Migraine Diet, a ketogenic meal plan for headache relief. So without further ado, I'll let Denise go ahead and get started, and then we'll take Q&A.
Right, we all set with my screen?
Yeah, it looks great.
Okay, great. Thanks so much, LJ. That was great information and amazing. So I'm going to take it just to the next layer and say, what do we do? How do we implement this diet? The first thing we're going to take a look at would be candidate selection. How do we choose these candidates? Well, of course, we'd like to have some evidence of benefit. We want to consider their prior medical history and any contraindications to the diet. The few big things that I'll mention would be an issue is if someone is in liver failure, renal failure, has active pancreatitis, those would be reasons, or a primary carnitine deficiency, which is usually diagnosed in childhood. Those would be some big reasons not to put someone on a ketogenic therapy. We want to consider their social considerations, what kind of family support do they have, and is the patient willing to go on the diet? Sometimes we have family that's more eager than the patient might be. Do they have the financial ability to do this? As LJ mentioned, some of the studies, they actually provided food, which is great, but some people find that keto can be more expensive depending on how they implement. The more fresh whole foods you buy, the more expensive it is. And are there any just overt red flags that you found, either socially or physically? Okay, there are 5 different kinds of ketogenic therapies, and I'll just run through these real quickly. The classic ketogenic therapy on the left there, that's a weight therapy. We usually calculate this on Keto Diet Calculator, and it's a pretty high ratio at 4-to-1, 3-to-1 that LJ mentioned, that 4 grams of fat to 1 gram of protein and carbs. So fat compared to non-fat, and again, at 4-to-1 is 90% fat. So we don't even do this in pediatric epilepsy very often anymore. You might have someone do this high of a ratio for a temporary basis before for a chemotherapy treatment, or to get them, really going. But with an adult, you generally can't get people enough protein on these ratios. If someone has a very high calorie need, a high metabolic rate, sometimes we can do that, but more often we're going to use a lower ratio. The next one over, a modified Atkins diet, it's generally just saying how much carb to have. So we may say, oh, just 15 or 20 grams of carbohydrate. Those are the main guidelines, and that the food should glisten and there should be lots of fat on it. But we don't give them on this specific protein amount, specific fat amounts to follow. People on modified Atkins very often eat too much protein. And LJ already mentioned that the extra protein is going to convert to glucose. On the bottom left there, you see the low glycemic index treatment, and that was created by our friend Heidi Pfeiffer when she was at Mass General. And that's I'll say more of a great starting point for someone with wanting to do this for cancer treatment. It's a much looser diet. It doesn't provide as high of ketones or any ketones sometimes because we're allowing more carbohydrates. So on LGIT diet, may be great for someone that's just considering this therapy as a starting point, and then you might move them up to another therapy. The MCT oil diet is 50 to 60% MCT oil in the calories. So it's very high. This is a personal opinion, I don't tend to use that because it ends up being, having some GI side effects, and it's a little bit difficult to tolerate that sometimes. But that leads us over to the modified ketogenic diet, which is what I use 95% of the time with adults and even with pediatrics in cancer or in other conditions. And I use a lot of MCT oil in that modified ketogenic therapy. We'll talk a little bit more as we go along. All these therapies have commonalities, and so fat is always the main source of calories, whether it's 70% or 90%. That's the main source. We provide adequate protein. Sometimes it's misconstrued as a low protein diet. It's not. By the time we get down to only the protein amounts that you truly need in a day, some people consider that low protein, but we're always providing enough. The carbohydrate is going to be between, as she mentioned, some of the studies, 50 grams a day at the top end, 50 grams at the top end, and sometimes even less than 20 at the lower end to get the high levels of ketones we're looking for. The therapy side of things, there's a physiological adaptation when someone goes into ketosis. I like to do this slowly for people so we don't have that keto flu you may have read about and have people sick as they're going onto the diet, onto this therapy. It's not necessary to have that happen. You can do it slowly. There's an emotional adaptation. If you think about it, when you tell somebody, wow, you can't just order pizza, you can't have the same Thanksgiving dinner everybody else had, or when you travel, you have to do all these different things. There's a lot on that. They're already dealing with a cancer diagnosis, and now you've taken away or adjusted something that's near and dear to all of our hearts, and that's their food. We're always going to supplement micronutrients as needed. We're going to keep a close eye on weight. We're going to make sure these people stay nice and hydrated, and in a lot of cases, we'll implement some fasting. The lab work, we do keep a close eye. It's very easy in cancer situations because usually the oncologists are checking labs every couple of weeks, so it's easy. We very often already have this complete blood count in a metabolic panel, and then we like to toss in a lipid profile to see how that is. Although I will say in cancer treatment, we're dealing with something much more immediate and severe, so the lipid profile is, I'm not so worried about it, but that's a whole nother day. And the carnitine profile, because carnitine tends to go low, or can very frequently go low on a ketogenic therapy, so we may occasionally supplement that, or better yet, improve the food sources of carnitine. How do we choose this therapy? Again, we've got to look at what their ability is. Are they able to cook? Can they afford the food? Can they afford someone to help them with cooking? Can they order meals? And there are lots of different options. Do they have family support? And is their physician or oncologist supportive of a ketogenic therapy? More and more as the years go on, I find more oncologists are in support of this because they're seeing the research, they're seeing that things are progressing in a way that is supportive, and we can also see that we're not going to do harm. The research has at least told us that, if nothing else, we're not going to harm someone. And I will say, just from a conversation I had 2 hours ago with a patient, he said he felt in control of what was going on, and he is seeing benefit from his therapy alongside his chemotherapy. But it was great to hear him say, I know that what I'm doing is helping me and I'm in control of what's going on. There's a lot to be said for that. What are the patient's goals versus the caregiver's goals? This can be two different things, and we'll talk about that a little bit in my case study at the end. What's their commitment level? We can do this diet through, any route. We can do an oral diet, of course, that's most common. But if someone has an enteral route and they have a feeding tube, a gastric tube, a jejunal tube, a nasogastric tube, all these things are sources we can use, these routes to get food into them, whether it be a commercial formula, better yet, a blended ketogenic formula, and in some rare cases we can use a parenteral nutrition to provide a ketogenic therapy. We're going to look at the protein and calorie needs and assure we're meeting those. And we can use these guidelines, 25 to 30 calories per kilo per day. That's a rough estimation. And of course, we're going to always use their intake and their diet history and see what we need to give them. We don't want to overshoot on the calories. That will limit the ketosis. And then 1 to 1.5 grams of protein is pretty typical. If we need to lower that down to the RDA for an adult, which is 0.8 grams per kilo, we can certainly do that as long as they don't have any nutrition issues. This picture, I love this. It gives a good idea for people who haven't really seen what ketogenic meals look like. Take a look at the top left at the 4-to-1 ratio. Again, 4 grams of fat per 1 gram of protein and carb combined. That's 90% fat. And you can see it took the equivalent of about 3 tablespoons of oil and mayonnaise to get to that level. And that's out of 400 calories. If you scoot on down to the lower right, you'll see a 1-to-1 ratio. That doesn't even look so far off of a normal meal if you think about it. There are about 4 teaspoons of fat in that between, 4 teaspoons between the mayonnaise and the oil there. So I like to start somewhere kind of between that 1 and 2-to-1 ratio for most people, because I find they can tolerate that, they can have success right away, and then we can move up as needed. But again, really rare and unusual to get people, to a 3-to-1, 4-to-1. It's not typical for adults. And then even in pediatrics, just because of tolerability of the diet, I tend not to do that, even though we could probably meet their protein needs. It's not the ideal. I mentioned that modified keto is where I tend to go. And why do I do that? I feel like this is, easy is probably too strong of a word, because the diet's not easy, making these kind of changes, but it's easier and it's succinct because we're giving them specific guidelines, and I feel like it's realistic. We're giving them specific grams to either weigh the food out, or specific measurements to say you get 1 cup of this, half a cup, 3 ounces of meat, and et cetera, versus a carbohydrate only restriction, such as, again, modified Atkins, where they only know how many carbs to take. What happens is people will come in and they'll say, well, I'm eating, only 10 grams of carb a day, but my ketones are only 0.5. I just can't get my ketones up. And very often they're really supplementing the rest of their calorie needs with protein and maybe having just a little bit of fat. So it's very helpful. We can give them something specific in all 3 macronutrient categories: how much fat, how much protein, how much carb. And I like to do this based on personality, because some people love to have a very strict guideline, just tell me exactly what to do. And other people are, oh my gosh, don't make me weigh anything, that would be crazy. And so we'll start out much looser again with a little bit of measuring. As we're educating people on keto, we want to kind of hit all these high, I'm just watching my time here. We want to hit all these highlights, and I won't go through every single one of these, but these are all the categories, and probably then some, that I'll go through during education. And education isn't a one and done with the ketogenic therapy. There are too many details. You might be able to put all this information in someone's hands, but then you're going to need to go through it over several appointments, and then have teach back and make sure that people understand what's going on. We want at minimum them to understand what is ketosis and what's going on there. And I like to make sure, if they're going to be using Keto Diet Calculator to calculate meals, that they understand that, or perhaps we're going to use Chronometer. I'm going to show you that in a moment, or some other type of an app. I don't really have any certain app that they have to use, but I want to make sure they understand what they're doing when they're tracking foods. And then this is just one example of a tracking app people can use with Chronometer. They're going to enter in the foods by specific measurements. So they can do it by weight, they can do it by teaspoon, tablespoon, cup, by pieces of, you can see 5 strawberries. So there are many ways they can enter it. And on the bottom right, you get the exact protein, the net carbs, which means net carbs is this, they subtract the fiber from the total carbohydrate. Just a quick note on this, on the labels there, first of all, there's no label law for net carbs, and so they can make it say whatever they want, but most products are subtracting out all the sugar alcohols also. And when they do that, you get kind of a skewed number, because they might be subtracting out actual carbohydrate, or maybe there's just additional fiber thrown in there. And so it can be skewed, but a true net carb is total carbohydrate minus fiber. If you look over on the left where it says 449 calories consumed in that circle, this is great. When you're on the app, you can hover over that red line and it'll show you that that's about 75% fat. So people get a real quick visual, because you can look at this diet in terms of the macros, like LJ and I were talking about. A lot of the dietitians, we think of it in macros. We think 2 to 1, 3 to 1, 4 to 1. But a lot of people are looking at this in terms of percent fat, which is fine. It's just another way to look at the macronutrients. So that percent fat, we're saying, wow, you need to hit 75 to 80% fat to get into the good ketosis. All the while, we want them to balance that fat, protein, and carb on a meal-to-meal basis. I like what LJ said about the one study where they said you don't get any more than 10 grams of carb per meal. If someone's going to have 50 grams of carb in a day, or 40 or 30 grams of carb in a day, we want that to be spread out. We don't want it all at once. Your body's going to take that carb, it's going to convert it to glucose. The higher the glucose goes, the less ketone production you will have. Prior to chemotherapy, some people are going to consider fasting. There's a little bit of research with this saying, wow, if you go into chemotherapy fasted, that may be more beneficial. But we have to be careful when going to chemo fasted. If they hadn't already been on a ketogenic therapy, weren't already fat adapted, and someone decides to fast for 2 or 3 days, they might go into that chemo sick, nauseated, keto flu, with electrolyte imbalances and slight metabolic acidosis. So I don't encourage that unless they already are fat adapted. Some people want to do a stricter keto and restrict their calories prior to chemo. Maybe they do a higher ratio for a few days or a week beforehand. That's fine. That may have some benefit for sure. But again, I'm also looking at the big picture here. And if you try to push people into something that they just can't quite achieve, or they hate, or they're nauseated, then we're going to lose them. So to me, it's much more important to make this achievable and attainable. And can we loosen the ratio and the calories between chemo treatments? I'm just going to, in personal opinion, I'm just going to say no. I don't like to do that. Some people, if they're at a really high ratio, and want to go down to, to 4 to 1, they go to 2 to 1, of course. But there are definitely some case reports where people have had great improvement with glioblastomas, and then for years, and then gone off their ketogenic therapy, and the tumors recurred very quickly. So I've heard, with some colleagues, these things happen, and I've seen some written up in case reports. So I really hesitate to say that you can go off the diet. We like to have people continue it as long as if they're seeing benefit, as long as they're willing. I would love it if it's a lifestyle change that they adjust to, and maybe they're not as strict later on after they're through with their therapies, but I'd like them to stay on some level of, a low level of ketosis. How do we optimize the diet? We want to maximize the ketones and minimize the glucose. We can do this by adjusting the net carbohydrate down. We can do this by watching the protein levels, as I mentioned, and keeping that in control. That's one of the biggest things we find is people coming in, they're eating too much protein. They think keto just means, a high protein diet, and that's not where we're going. It's a moderate protein diet. And then we can incorporate MCT oil. And I'm not going to go into great detail about MCT oil here, but I will say that you want to titrate this up slowly. A really loose guideline would be 5 to 10 mLs. That's 1 to 2 teaspoons every couple of days. I like to give it to people with meals and just have them get used to it and tolerate it. So over a few weeks, let's say 4 to 6 weeks, I'd love to have them up to 25% of their calories from MCT oil. You can certainly go higher, but that's a nice goal. And don't make them do that calculation. You calculate it for them and tell them, 3 tablespoons a day, or 4 tablespoons, or 45 to 60 grams, all depending on how they're manipulating their diet. Of course, we can take that ratio up, which I often do. I'll start it at 1 ratio, maybe a 1.5 to 1, and then a few weeks later, when they're adjusted, we'll go up to a 2 to 1 and maybe higher. Sometimes the calories are too high. We might want to restrict. Of course, we're supplementing exogenous ketones. We don't have enough data yet to say that I feel comfortable saying you should or should not use those. There definitely may be some benefit, and they'll give you a short, rise in ketones, but the jury's still out with those. And of course, intermittent fasting might provide some benefit. But who should fast? That's a good question here. Should we do it or should we not? Well, the benefits of fasting would be to decrease those glucose numbers. It'll bump your ketones. It'll improve your GKI, which is a glucose ketone index. I'll tell you a little bit more about that in a moment. And it'll increase autophagy. So those are all things we want in a cancer treatment. But there's some reasons we might not. We may have malnutrition, micronutrient deficiencies. If they're not eating enough in the first place, we certainly don't want to tell them to fast. And of course, if they have cachexia. Now, all these reasons on the right might be reasons that you don't even start a ketogenic therapy also. So, but someone may be, just able to maintain their weight. I'm fine with that, with starting them on a therapy, even if they've had a lot of weight loss, because the volume of the meals is smaller, and we frequently find we can get enough calories in with those high fat levels. They don't have to eat as much. Couple things to consider with medications. Steroids raise our blood glucose. We don't need any dextrose and IV fluids, generally, rare reasons that you would ever want that, so we'll stay away from that. Chemo may impact their ketosis. Metformin is commonly added in cancer treatments because it's a diabetic agent. It's been around for years, and it does not induce hypoglycemia, so there's no danger of that. So we find that metformin is even being studied in some cancers. Supplementation, I'm going to go by this a little bit quickly because for the sake of time, but we have some standard supplementation that we do and then other additional supplements. These are all keto supplements, not cancer-specific supplements. The one thing I'll caution is to think about with meds and supplements that you're thinking about the carbohydrate content. Some people in cancer treatment are taking a plethora of medications, and it can really add up with the carbohydrates. So I try to get them to only the things that they really want, that are very necessary, and if there are things that they don't even know why they're taking, to try and wean those off. The glucose ketone index is a theory of that the relationship of the glucose and ketones. It kind of gives us a measurement of how we're doing. And the goal here is to hit the zone of metabolic management between 1 and 2. And I'll tell you, not everybody hits this. People still have success even without hitting this. I'm going to then skip a little bit further to show you how you calculate this. We're going to divide the glucose millimoles by the ketones. Some of the meters will calculate this for you, so that's very nice. We measure glucose and ketones usually a couple hours postprandial. Some people wanted to see what they are fasting. That's also fine, but I like to see what your body's doing later in the day. It's usually when your numbers are highest. And not right after exercise is not the best time to measure. And then not after the same day as an IV vitamin C treatment, which is pretty common because that the reagent on the strip will react and you may have an abnormally high blood sugar show up. The goals here, somewhere between 50 and 100 on glucose, 60 to 80 is kind of a tighter range. If someone has diabetes, I don't want them down in the 50s and 60s, but other people can be. And then the ketones for adults, somewhere in the 1 and 4 range, but if they're higher, I'm happy, I'm cheering, that's fine. If adults go up even as high as 7, it's rare, but I'm okay with that if they feel well. And then in pediatrics, it's easier to get kids in great ketosis. So you might be able to get in that 4 to 7 range with the pediatric patients. Resources that we have, a few things listed. I will highlight Keto Diet Calculator is available. It's an online resource. It's free through the Charlie Foundation, and practitioners can sign up for this, and then you sign up your clients with their own private accounts. It's all HIPAA protected. And then the 2022 mastery courses that Beth and I have been presenting, and there's a foundational class and an advanced class, and we try to cover all the details on how to implement and monitor and manage these therapies. And I'm gonna skip these on the case study. I apologize. 2 more examples. I want to get right down to this and show you this patient with a grade 4 glioblastoma with a resection. She followed standard of care treatment. She's a little overweight. There was no physical exam on this for me. Of course, she was seen by her doctors. This was all done via phone before some people at that point weren't doing telehealth. And she didn't have any allergies. Her labs were all normal, and she had a lovely, supportive family. We put her on a modified ketogenic diet. I started her at a 1-to-1 ratio because she didn't want to go super high on her ratio. And she started slower than almost anybody. This is the slowest I would start somebody at 1 keto meal per day. And then every week we would go up. So she would do one keto meal, and then the rest of the day, she'd have whatever she wanted. Of course, we're encouraging no sweets and, you know, no pop and things like that. And then after 1 week, she would go up to 2 keto meals per day. And then the rest of the day, again, she could eat whatever she wanted until after a month, we had her fully on ketosis. This is just a snapshot of the keto diet calculator, so you can just get an idea how that looks. That's at a 1.5 to 1 ratio. So we went along, and after a few weeks, she is too tired to prepare her meals. And she said, I just don't feel as invested as everybody else wants me to be. She just wasn't really there emotionally. So we had a kind of a come to Jesus talk, and we discussed therapy as a medical treatment. I said, this isn't just a diet. We didn't just put you on a diet. This is part of your therapy. It's just like your standard of care. It's just as important, you know, we deem it as important as your chemo, as important as your radiation therapy. And I challenged her just to decide, take a few days and think about this and decide what you want to do. And thankfully, we're sitting here talking about her because she did decide to do this, but we had to find someone else to fix her meals. It was too much for her. So we didn't have to find a chef or anybody fancy. We found a nice lady who wanted some extra income, and she started using the meals from the calculator and just weighing them up for Beth. Her results, 4 weeks she's on the diet, her ketones were only 1 to 2. I don't even have her glucose readings, but there's no way that she achieved a GKI of between 1 and 2. This is a ketone level between 1 and 2. At 36 weeks, her glioblastoma is fully resolved. Her overweight is resolved, her fatigue is improved, and after 5 years, now it's going on 6 years, she has no evidence of tumor. Most people, less than 5% of people with glioblastoma live beyond 18 months. So this is monumental to live this long. Her weight is great, her energy levels increased, and she's still doing fabulous, and we still have contact, you know, about once a year. We just kind of check in. And the last thing is in her motivation. Everybody, you know, we have to have a why to do things. And she said a day without Jackson, as her grandson that was in the picture, is like a day without sunshine. So that was her big why, and she's still here for him because of all the treatments that she put into place. Here are references. Thank you so very much.
All right, thank you both so very much. That was phenomenal. We have just a few minutes here to take some questions. So I am going to, either one of you can answer this question. It is, so in cancer, is it more beneficial to drive down insulin or increase ketones? Ketone production is obviously important with epilepsy to promote a therapeutic effect, but is it the same in cancer or more linked to insulin IGF-1 suppression? So LJ, do you want to start?
Yeah, I would love to. Also, thank you, Denise. That was awesome. That's an excellent question, and also something that we're still trying to figure out ourselves. So in our phase 1, we also checked fasting insulin. And, you know, I think that the judge and the jury aren't out in terms of what's going to be more beneficial. Of course, insulin drives growth, and also BHB or ketone bodies have been shown to change tumor microenvironments. So I don't know if one is more important than the other, and we also just don't have that answer from what I understand.
And then to piggyback on that, when you drive ketones up, you are driving insulin down. I mean, it's going to go hand in hand. So I think it would be really unusual to have, you know, high insulin production and high ketones. I don't think you're going to see that very often.
I mean, maybe like with people who have insulin resistance, like I've had patients who have had insulin resistance for a very long time. And so it does take a minute for their insulin to reset and get into normal levels. But to Denise's point, there is a direct correlation with ketones and insulin and IGF-1.
Awesome. This question has been asked several times, so I think it's important that we talk about this. So there's a lot of people asking about, when do you decide to wean off the ketogenic diet? Do most folks stay on it for life to some degree? Like, kind of, where does that conversation go, and how do you make those determinations? And Denise, I'll let you take this one.
Yeah, so as I kind of alluded to that a little bit, we don't know enough to truly know, right? So we're just trying to figure this out. But if you think about other conditions, if you say, wow, I have diabetes and I'm just going to take metformin, and I think I'll just take metformin until my blood sugar is in good control, and then I'll stop taking metformin. Well, we know the blood sugar is going to go right back up, right? And so just on just a basic, common sense premise, if we don't continue keeping the body altered in the state that we believe is providing benefit, then I'm afraid that we're going to have, regrowth of the tumor. And again, just anecdotal reports and case studies a few times, and only in glioblastoma. I can't extrapolate. I mean, I do extrapolate this out in practice and say, I would recommend that you stay on this. If someone's seeing benefit, and most people want to, because they're seeing benefit, and they do, if we believe that that's what's helped. It's just like if the chemotherapy is helping and the doctor says you need 3 more treatments, then by all means have 3 more treatments. You don't say, well, but these, I'm good, right? So that's kind of how I feel about it. Again, if this is experiential and not data driven.
Awesome. And for our last question, because I think this is, it's an interesting question, and I really think it's good to think about, because there just aren't a ton of dietitians trained in ketogenic diet therapy for cancer. So the question is, in your opinions, would it be easier for a keto RD who's done epilepsy to manage patients along with cancer physician, or train the cancer RD on how to manage ketogenic diet therapy? What do you guys see that's happening across the field in terms of that?
Well,
LJ,
we're both, right? Go ahead, LJ, because we're both examples of that.
Exactly. I think, Denise, I guess it depends on your experience, right? Like, you've had so much experience, you have years of experience with keto and different disease states, because, we're humans. So cancer doesn't happen in a silo either. Neither does epilepsy, or I don't know, maybe it does for most people. But I think there's nuance to cancer that, you can learn, but there's so much nuance to keto. I don't know, Denise, how do you feel about this?
Oh man, so I think it's great. One, we have this pool of ketogenic dietitians that's already doing this for epilepsy, and oh my gosh, let's do it for other treatments. And sometimes people are restricted by their position, and there aren't enough hours in the day to even take care of the epilepsy patients. And so some of them do expand into private practice. That's what happened to me just organically. People were calling and asking, can you put me on the diet for cancer? Like, what? And once I saw some of the research, I said, sure. And I met him, met him at McDonald's and put him on the diet. It was crazy. And so, but we need the oncology dietitians too. So we need everybody. We need dietitians as a whole to embrace ketogenic therapies for all the research applications. And we need, the registered dietitians as a whole to embrace this and begin training. That's why I did the training. I wasn't trying to be a setup, but that's why I did that training, because we need so many more people than we have. And we need people to be well trained and to begin practicing and have people mentoring each other, so we can all grow and learn and have plenty of people, because this therapy is not going away. It's being utilized for many other conditions, and we need trained professionals in all areas.
I completely agree. And the one thing that I will say is, I got into this because I didn't want a cancer patient to be doing this on their own, because we are the nutrition experts. And so we should be the ones who are empowering these patients and providing them with education. So if we can all come together and do this, I think that's amazing. But all in all, dietitians are the nutrition experts. And so everyone has the tools, and we have amazing resources that we can utilize to learn from each other and make this, something that is valuable for people to use.
And I want to give a plug for the listserv. We have a keto dietitian listserv that if anybody wants on it, they can ask Laura about that. But that's a great resource, and we ask each other questions, and we give input, and we hook people up with resources.
Yeah, absolutely. Incredibly well said, ladies. And that is all the time we have for today. I cannot thank both of you enough. This was phenomenal. You were both amazing. To everybody that attended, like I mentioned before, we will be sending out the continuing professional education certificate by the end of the day tomorrow. You will also get a full reference list, which is 2 full pages of amazing resources and references that these ladies have provided. The recording will also be available within the next 1 to 2 weeks on our continuing education site. And I just want to thank everybody who listened in today on their support of these 2 and functional formularies. It's amazing having such a great turnout for an amazing topic. So everybody have a great day. and we will all be back for future webinars soon.
Thank you.
ladies.